Very good afternoon, and on behalf of Clinical Infectious Disease Society, this is our CIDS Webinar series on COVID-19, and this will be the third lecture on infection control by Dr. Ram Subramaniam, and the moderator of the session will be Dr. O.C. Abraham, who is a professor of medicine at Christian Medical College, Vellore. Again, certain housekeeping announcements to start with. I would request people to ask questions relevant to the talk for the day. For example, the OT infection control, other special situations, all will be dealt sometime later. This is with respect to general infection control in OP, IP, and COVID wards. I request people to ask questions relevant to this talk, and people who join in late, don't worry, there is a YouTube link, and that will be flashed across. And otherwise, you will have to just Google or just YouTube CIDS webinar. That is what you'll have to do. So late attendees or one of your friends who are joining in late, they do not have the access to the Zoom, because the Zoom one is restricted only the early 1,000 attendees, and they could do the YouTube link. And all these lectures, the day 1, day 2 lectures that we have done, have been put on our website, the CIDSindia.org, as well as it is there in the YouTube also. You have to type CIDS webinar, and you could access it. And so would be this day also too. And it's off to Dr. O.C. Abraham to introduce the speaker, Dr. Ram Subramaniam. And then we are set to go at the most difficult topic of all the thing, the infection control. Clinical ID is relatively easy with respect to COVID. Infection control is the most challenging thing. And I think Dr. Ram Subramaniam has done infection control. He's a chair, HICC chair at Apollo Hospitals, Greens Road for almost 25 years. And probably I don't think anyone would have held that position in the entire country for 25 years. And off to Dr. O.C. Abraham. Please go ahead, sir.
Good afternoon. Thank you very much, Dr. Nambi. Once again, welcome to the third of the CIDS webinars on COVID-19. Today's speaker is Dr. V. Ram Subramaniam, Senior Consultant ID Physician from Apollo Hospital, Chennai. One of the pioneers of ID in India, the two Rams from Chennai, Ram Gopalakrishnan and Ram Subramaniam. Another feather in his cap is that he is probably the longest serving HICC chair in whole of India, again, father of infection control also in India. To me, even more importantly, is an excellent teacher of ID. Great demand in CMA circuits because he can make difficult concepts very easy, lucid, interesting. So when it comes to COVID and infection control, we have seen everything from hazmat suits to decontamination booths. So all of us will have lots of questions. Now I will hand it over to Dr. Ram Subramaniam for this session on infection control, particularly in the setting of COVID-19.
Thank you very much, Dr. Nambi and Dr. O.C. You've given me a phenomenal build-up, and I'm going to have a tough time living up to it for the next half an hour or so. I will just share my screen now. Yes, I hope all of you can see. And the topic I'm going to talk to you today is about infection control with regards to COVID-19. I have a few disclosures to start with. We all know very little about COVID. It's been around COVID-19, which has been around only for the last about 3 to 4 months. Whatever we know seems to be constantly changing. I made my slides yesterday, and today I was going back to the net to check on something, and that is already outdated and something new has come up. We try to extrapolate whatever we know about SARS to COVID-19 or SARS coronavirus 2. Most of the SARS data was a little more easier to grasp because SARS gave us some time to, prepare ourselves in the sense that the person had to be infectious for 4 days. The person had to be symptomatic for 4 days before he became infectious to others. In other words, it was not, even though it was as bad, but it was not this, enormous in magnitude. The laboratory studies also with regard to treatment are all extrapolated from what we learned during the SARS epidemic. We still do not have consensus in most issues. We need to keep in mind the vast gap between India and the developed countries, but I can see visibly over the last few weeks that the gap is shortening. This was with regard to the resources available and the access to care, but we are now seeing that the shortage of equipment is much more pronounced in the developed world than probably in India. Maybe India is yet to come to that stage. And lastly, I have relied on the principles of common sense in my talk. So there are a lot of things which probably can be a little more complicated, but I've tried to keep it simple. You know, we don't know who's infectious, you don't know how long he's infectious, but we will take that into consideration, and I'm depending mainly on the data from WHO and CDC in my presentation. We all need to understand that what is most important is standard precautions with regard to infection control in COVID. And we need to reiterate the WHO's 5 moments of hand hygiene, that is use of hand hygiene, either hand washing or hand rub before patient contact, any aseptic procedures, after patient contact, after any procedure or having soiled the hands with body fluids, and after coming into contact with the patient's surroundings. We need to use soap and water if hands are visibly soiled. Alcohol hand gel anywhere in the region of 60 to 75%, usually around 70%, which is the usual concentration in most hand hygiene gels, is what is recommended. And we need to use personal protective equipment correctly. And as we discussed earlier, to know to dispose them of correctly to ensure that we do not cause infection to others. Now, this is a very simple slide, but probably this is the most important slide in today's presentation. With regard to healthcare workers who are directly providing care to COVID-19 patients, the type of personal protective equipment which is recommended is an ordinary 3-ply surgical medical mask, a gown, a pair of gloves which need not be sterile, and eye protection either with goggles or with a face shield. For aerosol generating procedures on these patients, instead of a medical mask, instead of a 3-ply mask, we need to use a N95 mask, a gown, glove, an eye protection, and probably an apron. So this is what is the basic crux of infection control for any of our patients with COVID-19. If we expand this to what else people in the hospital who are working need to use, all the cleaners need to use also heavy duty gloves. They also need eye protection, and also boots, so that they protect their footwear, especially when there is likely to be splashes. Visitors entering the patient's room need to wear only a 3-ply medical mask with gown and gloves. For all other parts of wards and corridor where other healthcare workers may be present when a patient is being shifted, no personal protective equipment is required, because this is often said that they are at risk. As long as the patient wears a surgical mask, if he tolerates it, you don't need to worry about others. In triage areas, for example, a secretary, as long as there is a 1-meter gap between the healthcare worker or the secretary and the patients, you need not give them a personal protective equipment. In patients who have respiratory symptoms, you need to maintain a spatial distance of 1 meter. And if possible, the patient has to use a mask. In patients without respiratory symptoms, no personal protective equipment is required. And in the laboratory, you need to be again careful with the use of a medical mask, gloves, gown, and also eye protection if flash is anticipated. The next question is, I've said that if we are using or if we are likely to perform any aerosol generating procedures, we need to use an N95 mask. So what are these procedures? If it involves open suctioning of airways, if you're doing induction of sputum, cardiopulmonary resuscitation, endotracheal intubation and extubation, if you are subjecting the patient to a non-invasive ventilation with a BiPAP or a CPAP, if a bronchoscopy is being done or a manual ventilation, in all these conditions, you need to use an N95 mask. For anything which does not involve this, a simple 3-ply surgical or the medical mask is good enough. What about nebulization and high flow oxygen delivery? Our main concern is the production of aerosols, which can cause airborne transmission. And most healthcare workers are very worried because even a violent cough or a loud talking in a person who's symptomatic can aerosolize. But it is believed that what minimal aerosolization happens is very minimal and it is unlikely to contribute to transmission of infection. But nebulization definitely causes aerosolization, and nebulization has been associated with an increased risk of transmission. But if you look at it, the nebulization causes aerosolization of the medicine which is used in the nebulizer cavity, which means strictly it is only the medicine which is nebulized or which is aerosolized. But probably because of the proximity of the healthcare worker during a process of nebulization, the risk is increased. So even though nebulization and high flow oxygen delivery is less likely to be associated with aerosolization of the virus, it is still advised that one uses an N95 mask during these procedures. Next is when you suspect a patient with COVID and you need to do a test, an nasopharyngeal or an oropharyngeal swab, you need to understand that a regular examination room suffices. You don't need a negative pressure room. You need to close the door of the room, and the healthcare worker should wear an N95 mask with a face shield or an eye protection, a gown and glove. A negative pressure room is not mandatory either for the performance of the test or for housing a patient who is not being subjected to any aerosol inducing procedure. Once, for example, if you use a room to test a patient for a nasopharyngeal swab, how soon can the room be reused? This depends on a lot of factors, including the size of the room, what is the air exchange or air changing capacity. Can you open the windows so that ventilation can be let in? It also depends on how long the patient is, how symptomatic the patient is, and whether he's coughing or sneezing while in the room. But to give you a practical answer, if you're using it for a person taking a nasopharyngeal swab for about a couple of minutes, in a few minutes time, the room can be reused. The chances of anything persisting in the room, which is infectious to others, is highly unlikely. So the room can be reused in a matter of a few minutes. The patient should be placed in an adequately ventilated single room. You need to ensure that contact and droplet precautions are followed. If there is natural ventilation, it is considered that the ventilation should be about 60 liters per second per patient. If single rooms are unavailable and patients are proven patients of COVID, they can all be cohorted. All patients' bed, irrespective of whether they have COVID or a suspicion of COVID, need to be at least 1 meter apart. Please remember this, that in all hospitals, at least specifically in times like this, there should be adequate spatial separation between each bed of at least 1 meter. Now, with regard to healthcare workers, it is recommended that there is a group of dedicated healthcare workers who look after only patients with COVID. In other words, a healthcare worker should not take care of a COVID patient and a non-COVID patient. These healthcare workers should wear a medical mask, again, a triple layered blue mask. They need a clean, non-sterile, long-sleeved gown, and gloves are necessary, which are not sterile. Please remember that boots, coverall, and apron is not routinely required during normal patient care. After the patient is taken care of, appropriate doffing and disposal of all the personal protective equipment is very important, and hand hygiene should be carried out. A new set of PPE is needed when care is given to a different patient. Now, in the event that you are seeing several patients with COVID, but you are not going into very close, prolonged proximity to the patient, it is acceptable if you wear an apron over the regular gown, and which can be changed between patients with regard to both gloves and apron. All equipment, including blood pressure apparatus, if you're using thermometers, should either be single use or disposable, or they should be dedicated equipment kept only for the use of the patient in that room. Never use it for anything else, even after disinfection. If there is a possibility that the patient who is in the room, a known patient with COVID, is subject to aerosol generating procedures, then the room should be adequately ventilated. There should be a natural ventilation with airflow of at least 160 liters per second, or there should be under negative pressure. There should be at least 12 air exchanges per hour and controlled direction of airflow when using mechanical ventilation. An N95 mask is now definitely recommended. And please remember, before entering the room, check to see whether the area around the nostril, the area under the chin are all tightly and snugly fitting so that there is no air leaking through the sides. And clean, non-sterile, long-sleeve gowns and gloves are indicated. I again stress there is no routine use of double or triple gloving or use of foot covers, covering of shoes. All that is not routinely recommended. It is more important that we follow the correct doffing of equipment, more importantly, and also to a certain extent the donning. This is recommendation from CDC. The first thing you wear is the gown. Ensure that the gown at least comes to the wrist area and covers up to the base of your palm. The mask or the respirator, it's either an N95 mask or a triple ply surgical mask, goggles or face shield, and gloves so that it overlaps the gown. This is very important so that when you stretch your hand, it shouldn't expose skin. What is more important is doffing. There are two ways in which you can doff. These are recommendations again from the CDC. The gloves have to be removed first, ensuring that when you remove the first glove, you pinch the outer surface and slowly remove the glove without touching any other part. And with regard to the second glove, you need to touch and fold it so that you remove it again without contaminating any aspect of your body or gown. Next is removal of face shield or goggles. Then you remove the gown. Please remember the front of the gown is contaminated, so your hands can get contaminated if you touch the outer part of the gown. You always need to touch the inner part of the glove, especially after the glove is removed. And lastly, the mask or the respirator. Hand hygiene is recommended in the end, but in between any of these stages, if there is a possibility your hand could be contaminated, please either wash your hand or use alcohol hand rub. This is the second way of doffing the personal protective equipment. You can remove the gown and the glove both at the same time, again ensuring that when you remove the sleeve of the gown, you touch only the outer part, and once you remove the glove along with the gown, then you handle with your bare hands the inner part of the gown so that you don't contaminate your hand. After that, you remove the face shield or the goggle and then the mask or the respirator, and subject yourself to hand hygiene or hand washing. What about in the outpatient settings? With regard to the current scenario, what is most importantly recommended is social distancing. You need to have a triage nurse who can triage and recognize early those patients who are likely or maybe having COVID. Hand hygiene and respiratory hygiene is very important in outpatient settings, so there should be posters put up to educate the patients. Medical masks should be used by patients who have respiratory symptoms. Appropriate use of contact and droplet precautions with regard to, again, mask and gloves is important. You need to prioritize care of symptomatic patients, and if they can be separately put in a waiting area with enough social distancing or physical distancing, that is recommended. And I repeat, education of patients and family about early recognition of symptoms, basic precautions to be used, which healthcare facility they should go to, all should be very clearly explained to the patient. Now, this is the slide. Again, I'm afraid it's a little busy slide of what personal protective equipment one needs to wear for outpatient setting. It is reasonably simple and similar to what is done in the inpatient setting. The healthcare worker should wear a triple ply medical mask, gown, gloves, and eye protection. Other healthcare workers, almost similar. Patients with respiratory symptoms, ensure that they always are provided with a surgical mask. Patients without symptoms, no personal protective equipment is routinely recommended. In the waiting room area, again, if you can maintain a distance of at least 1 meter between each other and there is no increased respiratory symptoms, you can get away with it. Otherwise, ensure that the patient is given a triple ply surgical mask. Administrative staff, no routine personal protective equipment if they can maintain a 1 meter distance. And triaging area, if they are likely to come into contact within a meter's distance, then the healthcare worker needs to wear a mask. What about standalone clinics? There are some recommendations given both by the WHO and the IMA. Always prefer telephonic appointments or online consultation in a situation where the risk is higher. Restrict the outpatient time to limited hours and avoid walk-in patients. Restrict the number of attenders who are likely to accompany the patient. Always maintain physical distancing. Encourage hand hygiene. Have a protocol for disinfection of the patient seating and couch. Avoid nebulization in outpatient care as much as possible, and encourage putting up posters and improve awareness on cough etiquette. Now, we are coming to a stage where we probably may run out of masks. So we are looking at extended use of mask or reuse of masks. So what do we know about it? If you look at principles for extended mask use, ensure that the face mask is always removed and discarded if it is soiled, damaged, or the person finds it hard to breathe through the mask. A healthcare worker must never touch the face mask. If you touch it or you adjust it, immediately perform hand hygiene. A healthcare practitioner should also leave the patient care area if they need to remove the mask. Never remove the mask in proximity to the patient. What about the duration of mask usage? So far, we have been using masks for a very brief period, maybe for individual patients for 5 minutes, 10 minutes, or a maximum of less than an hour. But now when we are looking at managing patients and having the mask on for a prolonged period of time, the European CDC recommends that you can use it for up to 4 hours at a stretch. But the CDC says probably you can use a mask which includes an N95 up to 8 hours per shift. And if the mask becomes wet or soiled, you need to change the mask. When you're using a mask, you are looking at both the conventional capacity situations, the contingency capacity situations, and crisis capacity situations. The conventional is what we are used to now. We have the luxury of changing masks. We have the luxury of frequent using. When we move on to contingency capacity, we need to look at both engineering, logistic, and patient care aspects so that we conserve the mask usage, which means you try to cohort the patients, you try to minimize elective procedures so that the mask is not used for routine surgical care. You also ensure that you minimize patient visits, the healthcare visits to the patient's bedside. And when we reach the crisis capacity situations, this may compromise either patient care, because it is going to limit the number of times a healthcare worker is going to visit the patient's bedside, or sometimes may compromise the healthcare individual's safety. So this is not recommended, but in case we come to that, what are the possibilities? I'll discuss in the next couple of slides. The recommendations for reuse currently, even the CDC has recommended that since COVID, the SARS coronavirus lasts only for up to 2 to 3 days, or the material on which it is found, especially if it is cloth or paper or cardboard, the virus is cleared within 3 days. The recommendation is to provide every healthcare worker with 4 masks. If you're using an N95 mask, 4 masks are given, which he uses on every subsequent day. And so you use the first mask again on the 5th day, which means after using, you remove it carefully and put it inside a breathable paper bag or inside a box, exact nature of which is not yet defined, and leave it for the next 4 days, and you can come back to using the same mask again on the 5th day. This is one area which is recommended. Whether this is safe, again, we are not clear yet, but this is one thing. The AIMS also had come up with some recommendations on how we reuse the mask through processing, which we shall see in a minute. Now, this is a study done from the US on the facial mask disinfection. They have tried various agents, including hot air oven, a UV light, soaking in 75% alcohol, soaking in a chlorine-based or a bleach disinfectant, using moist heat to see. And even though we don't have data on coronavirus clearance, this was done using E. coli, and they found that the E. coli reduced to significant numbers. But even though all these are tried, there are only 3 ways to reprocess which are now probably recommended. One is using an ultraviolet light. The other is using a hydrogen peroxide vapor. And the third is moist heat. Please remember, ETO disinfection is not recommended. ETO is carcinogenic. So we don't know how much of the ETO has residues in the mask. So using it is definitely not recommended. But using either ultraviolet rays or using hydrogen peroxide vapor is recommended. Now, this is again from the CDC, which has looked at it. And if the third-party agency, which recommends the process to use while reprocessing the mask, agrees to use, then they can be worn for all kind of patient activities. Otherwise, please do not use it for aerosol generating procedures when used subsequently. But there are certain important considerations you need to keep in mind, which are on the right side of the slide. You need to clean your hands with soap and water or hand sanitizer before touching or adjusting the filtering face piece or respirator. Avoid touching the inside of the mask. Use a pair of clean, non-sterile gloves when you don the mask. Visually inspect the N95 to see if its integrity has been compromised. Check all the components, that is the metallic nose bridge, the nose foam, and the elastic, all to see whether they are working correctly. If any integrity of any part of the mask is compromised, you cannot use it. And users should always perform a seal check to again see whether it fits tightly around the mask and the chin to see whether there is no leakage of air. This was what I mentioned earlier. This was in the AIMS website a couple of days ago. This is published on the 7th of April, but I don't see it today. The protocol for decontamination of coveralls and N95 respirators. They had suggested using 2 rooms whereby they hang all the masks and the gowns, coveralls over there, and then using a generator which generates hydrogen peroxide vapor. And depending on the size of the room, they had given very clear guidelines on what should be the cycle time, all that. And by hanging it and letting it for a contact time, you open it the next day and then you store it and you can reuse. And similarly, they also gave protocol for the reuse of face shields and goggles. This can be disinfected using 0.5% hyposodium hypochlorite and wiping it down with 70% alcohol. Now this is missing today, but in place of this, they have gone back to the CDC recommendation of giving 4 masks to a healthcare worker and asking him to use the mask every 4th day or 5th day as it comes, and store it carefully in a breathable bag. For environmental disinfection, you need to ensure that the staff who clean the rooms have to be given adequate personal protective equipment. We saw earlier this should include boots. This should also include a thick gloves, which is utility gloves. The room cleaning should always be preceded by a detergent clean and then using 0.05% bleach or sodium hypochlorite. If you're using a household bleach, which is usually at a concentration of 5%, a dilution of 1 in 100 is recommended. For surfaces which can be damaged by sodium hypochlorite, then ethanol, at least 70% alcohol solution has to be used. For toilets, 0.1% is recommended of hypochlorite solution. Linen and mattresses, 5% Lysol or 5% phenol, especially if there is blood or other body fluid contamination, and 1% hypochlorite solution for cleaning floors and ambulances. This is both from the European CDC and the Health and Family Welfare Department. I got these guidelines. With regard to biomedical waste management at the hospital, it remains almost the same. The segregation is the same, your yellow, red, white, and blue colored bins. But there are a little additions to this in the sense that you keep the color-coded bins in the containers in the ward based on the guidelines. A double-layered bag should be used. You need to collect and store biomedical waste separately prior to handing over to the agency. Use dedicated collection bins labeled as COVID-99. The label and the bags used for collection should also be labeled as COVID-99. You should maintain separate record and workers who can remove in timely fashion the waste. And you need to also disinfect the inner and the outer surface of the container, bins, and trolleys with 1% sodium hypochlorite solution every day. So these are extra precautions which you use to handle this biomedical waste along with your standard waste segregation and handing it over to the agency. Now we move to the last part of my talk on what do you do if a person, a healthcare worker or a person is exposed to a suspected or a proven case of COVID. You need to have a definition first. A contact is defined as anyone who provides direct care for a COVID-19 patient with or without a proper PPE. Anyone staying in the same closed environment as a patient with COVID, which includes workplace, classroom, household, or any gathering, and anyone traveling in close proximity of at least less than 6 feet with a patient in any kind of conveyance for up to a 14-day period after the onset of symptoms of the case under consideration. But there are a lot of questions which this opens up. When you say contact, how close? When you say duration of contact, what do you mean by prolonged? For example, when you say healthcare contact, a close contact for healthcare is defined as somebody who's within 2 meters of a person of COVID for a prolonged period of time. So what do you mean by this prolonged period of time? There's a lot of, a question which is raised, but it varies anywhere from 15 to 30 minutes. So if you're going to be very close to a patient for 15 minutes, which rules out most casual encounters. So if somebody with proven COVID stands in front of you, asks a question and leaves, strictly speaking, that is not a prolonged contact. We are looking at 15 minutes. This is defined by especially the Singapore guidelines and some from Australia and New Zealand also. And even the CDC somewhere along the way says that a 15-minute period is what is considered, though earlier a 30-minute contact was recommended. And anybody having unprotected direct contact with an infectious secretions or excretions of the patient, like handling the tissues of a patient in which the COVID patient secretions may be contaminating. This is further classified as a high-risk exposure, medium-risk exposure, and a low-risk exposure. A high-risk exposure refers to a healthcare worker who has had prolonged close contact. Again, when I say prolonged close contact, I'm referring to at least 15 minutes of contact in patients with COVID who are not wearing a face mask while the healthcare worker was also not wearing a face mask, or being present in the room where an aerosol generating procedure was performed when the patients and the healthcare's mouth were not protected. So this is high risk exposure. What do you mean by medium risk exposure? Medium risk is again prolonged close contact with a COVID patient who was wearing a face mask while the healthcare worker was not wearing a face mask. If the healthcare worker was wearing a gown, glove, or eye protection and a face mask instead of a respirator during an aerosol generating procedure, that is also considered as a medium risk exposure, which means you are going into the room of a patient who's on a ventilator, who's having some AGP or an aerosol generating procedure being performed without an N95, that will put you in a medium risk exposure category. Low risk is brief interactions with a lot of times which happens at the triage desk, briefly entering the patient room but staying away from him. Close contact with the patient was wearing a face mask while you are also wearing a face mask, but you're not sure about the integrity of it. And use of eye protection in addition to face mask or respirator would further lower the risk of exposure. So based on this, there are guidelines given as to how to handle the healthcare workers in a situation where we are detecting and doing contact tracing and isolating and quarantining contacts. This is very important to decide what you're going to do with each of these contacts. So if the patient has a if the healthcare worker has a prolonged contact with a COVID patient who was wearing a face mask, they will come under the medium or the low risk category. If it is a medium risk category, then you need to exclude that healthcare worker for 14 days and just monitor him periodically. On a daily basis, you need to check temperature and see. If it is a low risk category, that is a healthcare worker not wearing eye protection, not wearing gown or gloves, or wearing everything except an N95 for aerosol inducing procedures, you don't need to do anything. The patient can come to work every day, but you still monitor the temperature of the patient every day. If there is prolonged contact with the patient who was not wearing a face mask and there is a possibility of a high risk exposure, you exclude the patient from the healthcare worker from work and monitor him daily. Again, for medium, you exclude the patient from work. For low risk exposure, the patient can continue, the healthcare worker can continue to work provided he is again monitored on a daily basis. You also need to understand the importance of training the healthcare worker, especially with regard to donning and doffing, and to ensure that he handles patients with suspected COVID or proven COVID in a responsible manner. You need to follow up all healthcare workers who are involved in the handling of patient who is COVID positive. Either you can advise self-monitoring, which means they need to record their temperatures. For example, ideally, if I'm seeing patients on a daily basis, I need to check my temperature twice a day, or you can do an active monitoring, which can be done in the hospital twice a day. You need to always ensure that dedicated disposable medical equipment is used for these patients, and also keep in mind the infectivity of the patient starts at least 2 days before the onset of symptoms and may extend generally from 10 to 14 days after. Though recent studies say that the virus becomes non-viable after 8 days and the PCR test may remain positive. Last word, what about community exposure? Community exposure usually refers to a household member or an intimate partner or an individual providing care in a household without using the recommended personal protective equipment, or other people who may have come into close contact of less than 6 feet for a prolonged period of time. Recommendations: stay at home and ensure that you self-monitor and avoid contact with people at high risk for severe illness. So this is what is recommended for other people for community use. Lastly, this is coming up recently. I wanted to just put up one slide on this. The use of COVID booths, as they say, which sprays hydrogen peroxide or various concoctions of flavored material. There is absolutely no scientific evidence for this. We don't know, one, what exposure is necessary and what is the contact time necessary. We don't know how much of risk this is going to put to the patient's skin and the patient's eyes especially. So this is something which has no rationale and recommendation, and the WHO also supports this. So I think that is my last slide, and I would like to give my thanks to my department, my colleagues, and especially our registrars who have been stellar at this state. Lieutenant Colonel Kiran Kumar Kompella, Wing Commander Rohit Vashisht, Prithu, Krishna Prabha Haripriya, Bikram Das, Praveen, who have been very closely involved. And at a time whenever you read a paper, it is how the abstract looks all beefed up and very interesting. You say HCQS on role of HCQS, and then you read the introduction. It looks a little weaker when you see that it is not as robust. And then when you look at the result, you realize that it is probably something you cannot go by. In a situation like this, when everything is changing daily, I think we also should evolve with that and probably modify our views and approach in how we handle patients with COVID. Thank you very much.
Thank you very much, Dr. Amsubramaniam. Thank you very much for making it very simple easy to follow, practical and implementable in our situation. And there are lots of questions waiting for you. So I'll start with the first question. This is from an anonymous user. Can we check sputum for RT-PCR?
The current recommendations are only to do nasopharyngeal or oropharyngeal swab, but I think Dr. Rajiv Suman will take this up day after tomorrow.
Next is a very practical question, sir. What measures to be taken by healthcare staff for washing their clothes after returning from hospital duty, where they have to wear PPE over normal dress?
Again, there is a lot of confusion about it. Even our good old Dettol is good enough. The Dettol, at least in the product insert, says that it works against coronaviruses. Hypochlorite or common household bleach is good enough. 0.05% solution of hypochlorite should be good enough.
Next is how to resume OPD after lockdown.
We have to understand that this outbreak is going to have a significant impact on our lives. In other words, our life is never going to be the same again. Even though the lockdown may come down, even though the number of cases may come down, we shall always be living with the fear that when is a new case is going to come up, when is a new cluster is going to break out. So I think we have to learn to understand what we are learning right now with the response, with the relation to how we disinfect our clinics, how we disinfect our outpatients, how we use our masks, how we resort to cough and sneezing etiquette, and the importance of hand hygiene and hand washing, and avoid taking our hands near our face. So these lessons should stay with us permanently. So even if this lockdown goes, these 3-4 things which I said, I think cannot change.
Next question is about disinfectant tunnels. You answered that, but I would read out the question once again. Many places are using disinfectant tunnels, mist spray. Is it recommended? If yes, what disinfectant is used?
It is not recommended.
Thank you. Next is from Dr. Shikha Agarwal. There is no PPE in my institution except N95 mask. Can I refuse any emergency intubation or general anesthesia cases without adequate PPE? If I refuse, what legal actions can be taken against me?
As far as I'm not a legal expert, but as far as I know, I think there is no moral or ethical obligation for healthcare worker to take care of COVID-19 patients. Even though we take up our Hippocratic oath, even though we do all this, I think there is no legal obligation to do this. 2, especially if it's going to put healthcare workers under risk, we can refuse. This has been happening in the US. Colleagues of mine who are part of the electronic ICU, the EICU, which they run from here, tell me that the US doctors refuse to go into the room to intubate a patient if they are not given appropriate personal protective equipment. So this happens in the US. I think there's definitely, we don't have a standing, but I think I would agree that you can refuse.
Next is from Dr. Chindan. Sir, a recent article has shown that positive RT-PCR in the patient once labeled cured and negative. Do we need to change our discharge policy, or should we recommend home quarantine even after being discharged from the hospital?
Now, currently the government has recommended, I believe, a 14-day quarantine even after the patient is discharged. So I can't argue with that, but I can tell you the scientific evidence that a positive RT-PCR doesn't mean that the patient is still infectious. It detects the genetic elements like the gene expert. You cannot use a patient because inevitably you will residual material for several weeks or months also. So cultures of the virus show that probably they are cleared in 8 days' time. So a reasonable, again, a common sense approach would be a person is likely, especially if it is on home quarantine, less likely to be infectious after days. Are if he's 3 days without fever and cough, and at least 7 days after the onset of symptoms, which is usually in the region of 12 to 14 days for most people, he is no longer infectious, or he's no longer likely to be infectious. That will be a rough rule of thumb.
Thank you. Next is, what does BiPAP mean? BiPAP.
Positive airway pressure. BiPAP is positive airway pressure, which they use as non-invasive ventilation. Intermittent positive airway pressure and, BI, I don't get it.
Bi-level positive airway pressure.
Yeah.
Next is a question from France. Post-COVID strategy, what will change? You have to predict the future, VRS.
I think this is going to peter out to a situation where, as I told you, it's not going to be, we are finished with COVID, unlike which happened in SARS. I'm not as optimistic. Like MERS, we are still going to see cases. It is going to be a little more common than we see for MERS, which means this will spill over for several months. Whether this is again likely to mutate into a milder virus, which continues to be as infectious but less virulent, I don't know, because it may do that too for survival, evolutionary status. It may evolve. It is difficult to say. I'm not sure this is going to end up like flu, which is going to be annual, but it is definitely going to last several months, if not a year or more, before it comes under control. This is just my feeling.
Next is about masks. CDC insists to use masks for all the people. Is the disease really airborne? And if so, is it mandatory for the entire country to wear cloth masks as suggested by the government of India?
Now, this is again a very interesting question. If you had asked me this question about 10 days ago, I would have given you a different answer. What we know is that this is highly infectious. Most of the infections happen by direct droplet transmission, which means you need to be within 3, maybe 6 feet of a person for it to infect somebody. So that is the first thing. The role of droplet particles on inanimate objects and subsequent transmission, though is very, very small. The majority is direct. So just physical distancing will reduce the transmission of this virus to a significant extent. Having said that, the triple layered mask, the ordinary mask, should be worn only for all healthcare persons and for probably people who are symptomatic, whom you're strongly suspecting the possibility of COVID, or with respiratory symptoms, they need to wear this triple ply surgical masks. Till recently, we were saying none of the others need to wear a mask, but now there is a lobby picking up that even though these masks, which should be a double layered cotton mask, is unlikely to help prevent the transmission or protect yourself completely, it can offer at least some form of protection. If it is 50%, it is 40%, it is 30%, it is still better than no protection. So it is recommended. That's why all the public wear a cloth mask. But please remember, the surgical mask is only for healthcare workers and for people who are symptomatic. All others, cloth mask suffices, and it probably helps. We don't know yet.
Thank you. Can a person get reinfected after recovering from COVID-19?
With reference to infection control, yes, this is a very important point. Till again, a couple of weeks ago, we thought, or a few weeks ago, we thought that once a person recovers from the infection, he has immunity and he's unlikely, unless the immune system is compromised, subsequently, it is unlikely that he'll be infectious or he's going to be suffering from the disease. But recent evidence from Korea tells us otherwise. 5 to 10% of population have shown symptoms and have again demonstrated after clearing, they have again demonstrated the virus by nasopharyngeal swab. This is still too early for me to say whether this has any major impact or implications, but we need to wait and see, only to tell you that be careful. But whether for that reason, keeping the patient home quarantined 2 weeks after 2 negative PCRs in the hospital and discharging 2 weeks, we don't know. Common sense wise, it doesn't make sense to me if the person is cleared to keep him in further 2-week quarantine. But till we know more, I think probably the safer we are, the better.
Next question is about AIIMS policy. You had answered this, but I'll read out the question. AIIMS New Delhi provides 4+1 masks and advice to use on rotation and storage at home for its SCWs. Any opinion, better suggestion to the extended use of limited reuse of these N95 respirators?
Based on the current knowledge which is available, yes. Please, whoever is given the mask, that person should be the only person who reuses the mask. You cannot share masks with others. 2, again, whenever you handle a mask, I told you the 4 important points. Wash your hands before you handle. Do not touch the inside of the mask after touching the outside. Check the integrity of the mask and always do a seal test or a fit test after wearing the masks. So that if you're reusing masks, these 4 things should be absolutely mandatory.
Guidelines for seeing a patient in a regular general medicine OPD, PPE necessary or not?
In a situation where you don't know what you're going to, the patient, whether he's symptomatic or not, whether he's going to cough or sneeze, and there is a possibility that inevitably he's have to sit within 3 feet. You cannot keep a patient 5 feet away and then, talk to him on a routine basis. I would advise for all healthcare workers to wear a surgical mask, a triple layered mask for all patients in your outpatient, all doctors when you see patients in your outpatient.
May I also add that we have put up guidelines on our website, CIDS India website for this one. Everybody can look at it. Thank you. Next is, does COVID-19 transmit through blood? Are blood transfusions at this point of time, is it risky?
No, though we are finding that COVID is probably can be bacteremic. COVID can, the SARS-CoV can be bacteremic. SARS-CoV can be found in the fecal matter. We don't know yet the implications of the presence of the virus in these fluids, body fluids. As of now, it looks, even if they are significant, it should play a very, very small role in transmission. So it is safe to take blood transfusion.
Thank you. Next question is on reuse of N95 mask, which you already talked in detail. Next is, sir, any virus is electron microscopic particle. How they are assessing the viral half-life over various structures like paper, mask, steel, plastic, etc. Evidence-based.
I'm not very sure. Are they doing culture of the virus to see it is? I don't know. Maybe OC, you can shed some light. I'm not sure how they exactly process to see. I told you for the masks, they haven't done it for corona. They have done only for E. coli and found that it is probably equatable. But I don't know for the other things. I think it is culture. But OC?
I think they're asking about, since it's only an electron microscopic particle, but how do they access over a mask? One thing I've learned is that mask does not actually act like a sieve. There are other physical principles by which it inhibits the entry, transfer across the material, electrostatic force, and several other physical principles which I have not understood completely. So it's not simply a sieve. We think of it as a sieve, but it's actually not a sieve. Next question is about BCG. Gore, healthcare workers, BCG cross protection vaccine, still perfect. One will come under evaluation based on training of, I don't understand what he's trying to ask, but your comments on BCG and cross protection.
Very little knowledge available. It's a fancy theory, but absolutely no proof.
Again on PPE, 2 to 3 times, N95 mask, mask for everyone. Okay, sir, is there a particular thickness for face shield? Lots of companies using OHP sheets and selling to hospitals. How safe are they?
No, the face shield is only to prevent splash over the thing. Please ensure that, you know, face shield, as long as it is completely covering the eyes and protects the eyes, even if it is, unless it is going to break when there is a splash, which is unlikely, even if an OHP sheet is used, a thick one, I think it is acceptable. It suffices. You don't need a, you know, industrial grade face mask.
Next is very relevant. For COVID ICU, it's recommended that AC should be switched off. How do we go about this?
See, the AC, like tuberculosis, for any aerosol inducing procedures where the patient is subjected to, whether it is TB or COVID, when you have a common AC, this can facilitate passage of the virus to other areas and it is infectious. But other than that, I can't think of why you shouldn't have an air conditioner. If it's a separate air conditioner and there is no connectivity, there is no problem using an air conditioner.
And adequate air changes per hour.
Yeah.
Next question is about social distancing. Is 1 meter correct, or we need more distance? What is the evidence? Aerosol infectivity and their distance.
I think again, papers have shown that aerosol, which can be explosive, you know, even coughs, which can be explosive, can take your droplets to several feet, not 3 feet or 6 feet, even I think somewhere up to 27 feet it can travel or something like that. But that's why I said we have to use a little bit of common sense. You know, you cannot stay 20 feet away from everybody. At least maintain 3 feet, if possible 6 feet. But I think some amount of compromise we have to resort to.
Thoughts on repeated screening of frontline healthcare workers, I presume.
Very, very esoteric. I would suggest, even though people can be asymptomatic and can be infectious, at least monitor the temperatures. If the temperature is not raised, that makes it highly unlikely. So we have to now resort to practical ways to manage this. And, you know, you cannot read between the lines of all theory and then plan our, processes.
Any particular precautions for all HCWs working in hospitals treating COVID or non-COVID patients with regard to measures to be taken once they get back home after duty in the current scenario?
Now, this is a very practical question because a lot of us are very anxious. Can we go back to our families? Can we, share the room with our children? These are all very, very difficult questions to answer. So should we quarantine ourselves for at least 14 days after our work duty so that we are clear and then go back? Again, to me, they do not look like practical ways to handle. We are all, and I told you, this is not going to be ending with the removal of the lockdown. This is going to go on for several months. So we need to take precautions, but not be absurdly fastidious about how we are going to go about our lives. So my recommendation was, as long as we are able to, you're wearing clothing which are likely to be contaminated, which you should either dispose of in the hospital and wash it through the hospital laundry, or go home and are able to subject it to at least 90 degrees, which is what is recommended, heat in a washing machine, or subject them to disinfection and then do the cleaning. And you have a thorough wash before you interact with other family members. You maintain your temperature daily, if necessary, twice a day or if you subjectively develop fever symptoms, then you are careful to isolate yourself. Even though, again, the question asked would be, but 2 days before the onset of symptoms, you are infectious. So aren't you putting people at risk? This is, this is not practical lifestyle. You have to learn to work around with what you can manage.
Thank you. Next is from Dr. Sunitha Reddy. Is nasopharyngeal/oropharyngeal swab an aerosol generating procedure?
Any explosive cough can generate aerosols, and you're going to, fiddle around the back of somebody's throat. There is a strong possibility he's going to cough out, violently. So for that matter, I think it is preferable. But if it is also recommended that if you don't have an N95 mask, you can make do with a, face shield and a surgical mask.
Can N95 mask be sterilized using plasma sterilizers?
Yes, there are measures. As I told you, the AIMS document, in fact, said you can do generation. Otherwise, we have tried it using STERAD. STERAD is a, hydroxyl ion. It's a hydrogen peroxide vapor only. We have tried it in that. It maintains the integrity of that. We have done some minimal work in our hospital, and at least the integrity seems to be well preserved. So if recommendations come to an extent that we have to do it, I think that is something we can resort to.
Precautions to be followed in routine pediatric OPD for doctor and nurse while seeing patients with respiratory symptoms.
Now, pediatrics is going to be very, very difficult because most children come in with cough and colds. And we already have seen that COVID-19 in children is very mild illness. They're not sick kids. They are, happy kids running about, which can act as reservoirs and spread to others. So it is very difficult. You have to use a lot of common sense in deciding how you're going to handle them. And especially with kids being asthmatics, how are you going to nebulize them? Now, these are questions for which, unfortunately, OC, again, you can add your 2 pence worth, but I don't have a definite foolproof answer. You have to judge every case by its merit. You have to use your clinical sense. You have to take precautions, which means if there is a possibility of aerosol generation, you need to use an N95. Otherwise, ensure that you wear a mask. It's very difficult for you to put the mask on to kids who may be coughing and sneezing. So there are a lot of issues which don't have answers. So I don't know. OC?
I agree fully with you. Only thing I will add is stringent hand hygiene. Be obsessed about hand hygiene. Precautions while doing CT scan, and what PPE to be used for sonography while doing sonography.
I think sonography, the same precautions, which means a gown, a glove, and a mask would suffice. You're unlikely to have something on your eyes. So that's unlikely, and remove it and throw it before you leave. There were discussions in our WhatsApp groups about how long the CT scan room should be disinfected after one person is done. And I saw people writing about 1 hour and 1.5 hours. These are not very practical measures. As I told you earlier, if the person is not phenomenally coughing and sneezing, in which case anyway, you wouldn't be able to do a CT scan. Assuming that he may be coughing, but it is mild, you can probably reuse the CT scan room in a matter of if you wipe down the table where the patient could have, lied down, you can reuse the room in a few minutes time. So again, as I said, we should always temper a little common sense with practicality when we approach this.
How to clean monitors and screens of COVID patients? What solution and what's the contact period?
We use Bacillol solution. Bacillol contains alcohol derivatives, and I think a 25-second contact time is recommended. For bleach, at least 10 minutes contact time, but for instruments, Bacillol, which has a 30-second contact time, is what we recommend it use.
Sir, your opinion about 28-day versus 14-day for quarantine period?
Again, as I told, I would reiterate, most studies are now coming up showing that it probably dies within 10 days time. So 14 days and two negative nasopharyngeal swabs should be more than adequate. But I think if you are more careful, the government is being careful. So we need to learn along the way.
You answered about the sanitizer sprinkler walkthrough. How to clean instruments like laryngoscopes used for proven COVID patients?
Again, I think alcohol disinfection is probably what we can do, and or steroid is another option, because these can be put through steroid also. So,
is the efficacy of washing hands with ordinary soap and water beyond any doubt?
Yes, that's what again, there are a lot of memes going around that something which can be destroyed by a 10 rupee soap, people still haven't found some way to get rid of it. But yes, soap, because it has a detergent action, it is good enough to get rid of COVID.
Filtration efficiency of N95 masks and surgical masks with particle size which capable to block the carrier. Any difference between KN95 respirator and N95 respirator?
I don't know what is KN95. We have FFP2, FFP3 respirators, and we have N95 mask. The N95 mask basically, can filter off 95% of particles above 0.3 microns in size. Now this COVID is about 0.1 micron. And the FFP2 has a efficacy of about 92 to 94%, which is almost equivalent to N95. And the FFP3 is almost 99.5% efficacious in clearing particle size of more than 0.3 microns. I don't know what is KN or.
Even I don't know, I'm not sure what it is. Chlorination of water, household use, how effective is it?
SARS-CoV is not spread through water. So, good old boiling or chlorination, whatever, filtration, whatever is good enough.
How to disinfect vegetables?
Again, I feel we are spending a lot of time, energy, and effort into things which probably don't make a very big difference. You wash your vegetables like you would do, and ensure that you wash your hands after handling the vegetable. That is good enough. You're not, even if you're eating it, you're not going to put COVID into your, it's not going to be harboring, and you're going to cook your vegetables. So what is more important is the hands. Washing with simple, good water is perfectly fine. Maybe I'm trivializing it, but I think that's all we need to do. This fear about, newspaper.
Relevant question. Precautions to be taken by family members while performing the last rites of a positive patient. Any evidence of virus being viable and infectious in a dead body?
I'm not sure with Dr. Subra is going to take this up, because I didn't specifically look into because special situations, I didn't look into this. But the virus generally becomes non-viable once the person dies. But can it survive for a few hours? Yes, possible, it can survive, as long as we handle the body as minimally as possible. I think right now, if they are going to pack the body, anybody who dies in the hospital, pack the body, as long as we handle it minimally and wash our hands, there shouldn't be any issue.
Please illustrate the current triage process at Apollo from the first point of contact with patients and in the OPDs. How do we handle the asymptomatic carriers?
I don't know, because we don't know who's asymptomatic carrier. So with regard to asymptomatic people, I don't think we can say anything, because we don't know.
Can you spell out the current triage process you have in the hospital? That may be illustrated.
Two ways in which the patient can come into Apollo. One is through the outpatient and one is through the emergency. The outpatient, we have a separate fever clinic, which is a triage area, which is completely outside. Most of the routine OPs are all shut down. So there is a triage area where person with appropriate equipment, which mainly refers to mask and gloves, are seated. So the persons, they have a questionnaire done. They have a consent taken to tell them that because they are in the hospital, there is a higher risk that they may be exposed to COVID, and I'm willing to treatment in the hospital. There is one consent form, and then the pulse blood pressure is taken. The doctor takes a questionnaire. We tend to do, in cases where we suspect a chest X-ray and a CBC, if it is indicated, to get a rough idea whether there is a process going on. After, of course, oximetry to see whether there is any clinical, because we find there are a lot of patients who don't complain of dyspnea, but you check your oxygen saturation, it is under 90%. So oximetry, chest X-ray, and CBC would be simple tests to screen off. And this is done by a staff who treat every patient as possible COVID case. And if any of them come positive, then they are routed to the emergency. If they need admission, they go straight to Vanagaram Apollo, which is the hospital designated for COVID cases. Other cases which come through the emergency, right now we have two emergency, one doctor and a nurse who are always fitted in a complete, full gear, so that if there is a crisis, somebody comes in an arrest, they can immediately intubate the patient without wasting time on wearing equipment. So during one shift, a doctor and a nurse are always, in full gear, and they are in a separate area so that if there is an emergency, they can handle it quickly.
Disinfection of spectacles.
A good alcohol, this thing would do. You have alcohol wipes, or you can use the alcohol. 70% alcohol is what is recommended, at least 70%, and wipe it down. That's all.
Any special chemical like chlorhexidine for oral care of COVID positive patients?
No, not that I'm aware of. The usual care you give for any critical care patient is what is given.
What precautions to take when we have to examine regular non-COVID OPD for diabetes, hypertension, etc.?
I think you need to treat every patient as a possible COVID case. So the same physical distancing wherever it is feasible, the same wearing of a mask, and washing your hands between every patient, and disinfecting. In fact, before I see a patient and the patient walks in, I ask the patient to use alcohol hand gel so that his hands are clean and he has a mask, I have a mask. And wherever there is a doubt, periodically, I clean the areas where patients are likely to touch. And as long as I frequently wash my hands, I don't think there should be a risk.
Is raincoat advisable as PPE?
I think if you're desperate, probably, but not otherwise.
Reinfection, you addressed the question. How long can the virus particles stay in there?
Very, very little time. Again, theoretically, there is a difference. Usually, the ambient ventilation and the ambient airflow should clear it quite fast. So I wouldn't worry about them sitting on or floating in the air for several hours. No.
We have almost come to the end of our allotted time. A couple of questions. Will this infection strategy, I suppose it's infection control strategy, prevent other infections, especially nosocomial infections?
No, if you're looking at maybe chickenpox and measles and tuberculosis, yes, but otherwise I don't think it's going to make a big difference.
We will take this as the last question. A healthcare worker who had low-grade fever for 1 day, only 1 day, during his COVID ward posting and is tested negative by PCR, can he go back to COVID ward duty after 7 days?
I would think so. We see a lot of people who come with a fever of 1 day duration and then perfectly fine another 2-3 days. So if they are perfectly fine, we let them work. And if especially the COVID test has been done, I think that's perfectly fine.
So we have come to our 1 hour mark. Thank you very much, Dr. Subramaniam. You made it very simple, very practical, based on good evidence, up to the minute evidence, and you have answered a lot of queries. Thank you very much.
Thank you, Osi.
For everybody who asked, the presentation will be available on YouTube. Please search for CIDS Webinar series, or you can go to our society's website, CIDSindia.org. Thank you very much, and thank you once again to Dr. Nambi and the Hallmark team. Thank you very much.
Of comments to make, and regarding the oral care of COVID positive patients, there is some data using povidone iodine that had some kind of positive effect, and then the routine with COVID, probably NCL may have some effect, we do not know. And regarding resources with respect to dead bodies, I think the Ministry of Health and Family Welfare in their website have a beautiful guideline on handling dead bodies, and infection control in standalone OPs and clinics. The site has a guideline on infection control in standalone clinics. And probably it's a 4-page document, something very practical. And to sum it up, with infection control with COVID, which is very challenging, I think what we need to follow is standard precautions. Most of the situations, what we need is just a AAA mask, alcohol-based hand rub, and a glove in certain situations. So that would suffice for most of the situations. N95, that should be restricted to only for aerosol generating procedures. What we need to understand is we are not running a sprint race, we are running a marathon. So we have to be judicious and careful in the use of PPE, but at the same time, we should not risk ourselves too. For most of the situations, follow standard precautions. That means use alcohol-based hand rub, follow WHO 5 months of hand hygiene, mask, surgical mask for most of the situations. I think we need to stick to that and then be prepared for another 2 to 3 months to follow this as a routine and assume every single patient that we're going to manage, let it be the OP or IP or the ICU, could be COVID, could be a potential COVID patient. That is something that we have to be very clear. Thanks. On Saturday afternoon, you've had a good audience, and we would see you again on Monday afternoon for a session on diagnosis. That will be by Dr. Rajiv Soman. Thanks a lot.
Bye, Nambi. Bye, Ramsub.